Okay, good afternoon. I presume you can hear me? Yep, okay. So I'm Mark Treleaven. I'm the Product and Marketing Director at First Data Bank. I'm a health informatician, so I'm a technologist. I'm not a pharmacist and I'm not a doctor. So if you ask difficult pharmacy questions or from a clinical perspective, I'll do my best to answer, but I am not a pharmacist or clinician. My business and the organisation I work for employs several pharmacists and several hospital doctors and GPs who actually produce the solution. I'm here representing the sort of technology side of the business rather than the clinical side of the business. Just a quick hands up. Do we have GPs in the room? Pharmacists? CCG leads? Health and life science? Pharma? Okay, so we've got pretty much the whole health ecosystem. So thanks for staying. I know it's been a long day and it's been a long day chairing, so thank you for keeping us to time. I'll briefly talk about medicines optimization that's being delivered by First Data Bank. We've been working on this for the last couple of years from an initial concept, which I presented last year, to where we are today. So I'll explain where we've got to and what the next steps are in terms of our journey for medicines optimization and providing technology to support medicines optimization at the point of care and within CCGs and CSUs. Did anybody come to my session last year? I can say what I like then. Okay, so medicines optimization, there was a session yesterday in the long-term care condition stream around medicines optimization from a diabetics angle. Did anybody attend that one? Because that was sort of from a clinical angle what was medicines optimization was about. From a diabetic viewpoint, if you actually optimize the use of medicines and actually manage people's diabetes, potentially the view is you could save about £500 million from people attending A&E. So there's a huge potential pathway saving to the NHS, and it's not simply about medicine's cost. So it's optimizing the spend on medicine. It's not about driving down medicine spend. So if you think at the end of this, we're all talking about taking costs out of the medicine budget, that's not what we're doing. What we're trying to do is make sure that the NHS and patients and patient outcomes are optimized by the use of the intervention. And there are 900 million prescriptions every year in the NHS. It's the most common intervention that the NHS is going to do to a patient to improve or manage their healthcare. Medicines optimization includes driving down variation. There's a huge amount of variation in the use of drugs within the NHS, and most of the systems out there today look at how the prescribing view rather than the dispensing and the clinical patient view. So they'll show a variation across historically 150 PCTs, and for if you take proton pump inhibitors and the use of proton pump inhibitors across the NHS, there's a six-fold variation in the use of that intervention across the NHS. And somewhere in that six-fold variation in use across PCTs is good. But at the moment, nobody really knows quite where good is. What people try to do is manage out from outliers into the middle. What we're trying to do with the new technology we're trying to bring to the market is actually look at it from a patient perspective, not a drug perspective, and look at something that's clinically sensitive and in line with evidence-based best practice, and thus reduce variation in prescribing and improve patient outcomes. So historically, FDB has been providing clinical decision support at the point of prescribing in primary care, in the acute sector, in mental health trusts, to support clinicians prescribe safely. So for the last 30 years, we've been developing a solution which is now implemented across the NHS to actually improve the safety of medicines usage. What we're now doing is extending that solution to include best practice and a view on the most cost-effective way of providing that medicine. We're the only UK-based CDS provider that's got NICE approval. So NICE came and spent two years reviewing our content and editorial policies and gave us a tick in the box to say that we actually are acceptable to NICE to actually provide content through their knowledge portal. So we're the only CDS provider that can do that from a medication angle within the UK. Just to show you some of the people we currently work with. We work across the whole spectrum. We work across primary care. We're embedded within TPP System 1 since the day it started. They've been using our content. They use that content in hospitals, they use it in community, and they use it in mental health as they deploy it across the healthcare community. We work in community pharmacy, so we have a view from a dispensing perspective from Boots and from Lloyd's Pharmacy, so they use our content. And we are embedded in most of the acute sectors, acute systems, which are looking after prescribing, transcribing, dispensing within an acute sector. So we have a sort of holistic view of the use of medicines. Historically, that's all been about safety and improving safety. So it's looking at contraindications, drug doubling. Last year, 2 years ago, sorry, we launched dosing. So we have predefined dose based on the patient context. And we'd love to see that implemented to, again, further improve the safety of medicines use in the NHS. So that's our core platform. If we now move into the world of medicines optimization, this comes from the King's Fund report, which looks at when you're actually trying to prescribe medicines, you're actually looking at it from a multiple axes. From where we used to live in First Data Bank is about minimizing risk. So we know we're going to prescribe medicine. We know that there are potentially some contraindications, some precautions, some drug interactions. What we're now saying is that we need to maximize the effectiveness. We have a constrained budget. We need to make sure we're getting the most money, most effective outcomes from the investment in drugs. We absolutely want to prescribe the cheapest form of that drug. We don't want to waste the NHS money and taxpayers' money. So if we know what the therapeutic output is, we want to make sure we are using the cheapest drug to actually use that, to deliver that. And absolutely, from a medicines optimization perspective, it's about patient compliance, patient adherence. 300 to 500 million pounds worth of medicines dispensed to patients aren't taken, are wasted. And there's a huge piece around how you engage with patients to actually improve compliance, concordance, improve outcomes, and stop the waste of medicines. So that's the world of medicines optimization in the round. From a technology angle, we can cover off 3 of those. From a patient engagement angle, it's much more about a service engagement. It's about how you have that conversation with a patient about the drug, about some of the side effects they might experience, how they're going to feel for the first 3, 5, 7 days of taking that drug, which is a basic information exchange at the point that prescribing decision is made between a clinician and a patient. There are some things you can do from a technology angle, but we're not really focusing on those at the moment. So what we've developed is some technology which can be delivered in multiple different use cases. So at the point of prescribing, we are working with most of the vendors in the primary care space to integrate our solution. So at the point of prescribing, we can explain to a GP whether the prescription is evidence-based, in line with NICE best practice, whether it's the most cost-effective delivery of that medicine, and whether it's safe. So that's working at the point of care as you prescribe, integrated within those clinical applications, not as a bolt-on. Integrated, we're working with those vendors to make sure it's as seamless and as clinically intuitive as possible. We then move up a layer, case management, risk stratification. So we have the ability to review patients historically over a year and actually look to see whether the drugs they're currently on are evidence-based practice, are the most cost-effective, or are safe. And we can create a case list, and we can then working with a number of different vendors to deliver that case list for change back to GPs, medicines management teams, to actually affect that change as a service delivery component within a meds management team. So, and help them manage the caseload and workload of actually changing a prescription. And at the top level, we can use anonymized data at a patient level, patient-specific, to actually report on how CCGs, how individual GP practices are performing and compare them. So you can use it anonymously at the top level, as a case management tool at the middle tier, and as a point of prescribing tool at the bottom tier. So that's what we're trying to create. And I'll explain some of the work we've done in terms of validating that solution. But where we're trying to build a solution is looking at extending the patient inputs to make it patient-specific. So if we know the FEV1 score of a patient, let's make sure that the prompt we actually provide to the clinician when they're looking at renewing their inhalers actually takes account of that FEV1 score for a COPD patient and actually explains what the first-line treatment should be, or if they try first-line treatment, what the second-line treatment should be. And I'll give you some screenshots of what that might look like in a clinical system. We take those patient inputs, we take our medicine's content, and then we provide best practice, cost-based, and safety alerts back to a clinician either in real time as they're prescribed, or as a caseload or a case list, or as a report to show how people are benchmarking themselves against best practice, safety and cost. Or they can look at a diabetes cohort, or they can look at a COPD cohort, or a ischemic heart disease cohort, and actually report where they are compared to their GP practices within their CCG, if that's how they want to do it, or at a CSU level. So we have two solutions. It's the same solution at the back end, but used differently. There's some of the content resources we're using. So we're taking any national evidence that exists and codifying that and making it computable. So you don't have to read a 125-page nice guideline on how to manage diabetes. We've actually done that work. We're taking the information out of the patient record, synthesizing that with medicines information, and presenting the most clinically sensitive information back to a clinician we possibly can at a point of prescribing, or as a case management tool, or as a peer review tool. So how does it work? We take a set of inputs from patients, from the patient record. We look at what NICE says, how you should trigger, where you should trigger, what the FEV1 score should be, what the HbA1c score should be, and then actually report back to the clinician what they should be doing, and then provide back the evidence so you can go and look at the evidence as well. So we don't produce that evidence. That's nationally available evidence. We just synthesized it and made it available. This is a very simple rule, which actually codes. We look at the age of the patient, we look at the current condition, we look at the previous medications. We look at whether the patient is coded to have diabetes. Just for fun, there are 447 different read codes that can be used to code diabetes in the patient record. So we have all 447 codes in our system, and we check for each one of them. I won't even try to pronounce that, as one of the GPs can. The 4 read codes, 101 read codes, 17 read codes. We check for all of that. We then check whether they've got neuropathy, whether it's not based on diabetes, then whether it's male or female, and there are different measures for male or female, and then whether or not they've reported that in the last 3 months. And we do all that in real time and present that information to the clinician so they have the best information they can at the point of prescribing. We've gone around the country and validated this solution, so we've been engaging with CCGs for the last year, and we've done 3 tranches of validation. So we've taken our rules engine. CCGs have given us anonymized content, patient records. We've run that against our medicines rules engine, and we can now report on that to each CCG. This is the first piece we did with 450,000 patients from 12 CCGs. And the first thing we ran was cost-based analysis. Are the CCGs using the most cost-effective form of that drug? And we were identifying still around £3.47 per patient on average to actually deliver cost savings potentially back by using a cheaper form of the drug. And more worryingly, we found about 10% of patients had an error, an unsafe prescription in the last year, which could have caused an attendance at A&E, or it definitely has done them some form of harm, whether it's minor harm or major harm, which is pretty much in line with what the national view is about medication safety. Second tranche, 280,000 patients from 8 CCGs. And this was specifically looking at our safety rules. And these numbers look quite low, 2.6, 4.1, 2%, 2.8%. But if you actually picked out one rule, and the use of methotrexate, and there's a safety rule authored by, I think, Pincer, to say that if you're on methotrexate, you should have a liver function test every 6 months. Nowhere in the record for 35% of those people on methotrexate could we find a recording of a liver function test. That's not to say one wasn't done, but but it wasn't in the patient record. So there's a question of how that clinician is managing that patient without knowing whether or not a liver function test was run and what the results were. Slightly worrying for those people on a very, very dangerous drug. The most recent set of validation we've done is around best practice. We looked at 2 different long-term conditions, diabetes and COPD. And these are the actual patients who are identified with diabetes whose drug regime was currently not in line with evidence-based practice according to the patient record. 24% of patients are not being managed in line with NICE guidance according to the information held in their patient record. 22% of patients are not being managed according to NICE guidance in line with the data that's held in the patient record. So this is a retrospective view over a year, so we're trying to show what the value might have been had we had the system installed. What might it look like? We're trying to make sure that in a GP system at the point of prescribing, it's intuitive, it's integrated in the workflow, it's clinically sensitive, it's validated with the patient inputs, it's relevant to that point of the prescribing journey, and it will actually do the switch without switching out to another system or back into the GP system. So it's as seamless and easy to use at the point of prescribing as we possibly can make it, because that was a clear piece of feedback we got when we did our market research, was that we'll turn it off if we can't use it. If it just gets in the way and is irrelevant, we'll turn it off. So we try to make it as intuitive, as simple to use, as effective as it can be, to not get in the way of clinicians doing their job. What might it look like? This is a view of a cost switch, and we're saying you can save potentially £7.99 by switching to a generic. This one is looking at best practice for COPD, and currently they're about to be prescribed salmeterol CFC-free inhaler, and we're actually saying first NICE evidence says this is what you should be doing. It might be more expensive or it might be less expensive, but this is the best practice for treating that patient at the point of prescribing. So you can ignore it, you can decline to acknowledge that, say actually I know better about the patient, I'm not going to follow NICE guidance, or I can accept it and it will make the switch. Here's a switch that you could be making, but we're saying there's a contraindication. So you might not want to make that switch because it's contraindicated for that patient. But we're making that information available. And all the time, we've got the links out to the evidence so you can actually look at it. This is a full medicines use review, which it could look like. So it's looking at all the drugs with the patient in front of you and actually saying, through all of these different areas, these are the changes you could make with that patient in front of you. So you're doing a medicines use review on the fly with the patient in front of you, automated with very little engagement from either the clinician or the pharmacy team. To make it work, we have to be able to localize it. So we have the national guidance, we've computerized that. We now have to make it localized so you can switch rules on and off at a CCG level if you don't want that rule deployed. We have over 700 rules we can deploy. If we deployed all 700 rules in day one in a GP practice or in a CCG, it's probably going to cause huge overload in alerting. So you may want to decide how you want to implement those rules and which ones are most important to you. We're including in the solution formulary support. So as you pick a drug within a clinical system, a GP, local formulary support will fire and say, actually, for that your local CCG or CSU, we've decided that you shouldn't be using that drug at the point of prescribing by GP. It's been decided for acute sector. And here's another one. Where are we today? Last slide almost. We have a number of early adopter CCGs we're currently working with. We'll go live with our first integrated solution in about 4 weeks' time. And we have a number of CCGs who are working with us as early adopters who will validate the solution further before we go to mass rollout. And we've got about 15 to 20 CCGs who actually want to actually deploy the solution when it's available as we go through into the autumn. That's what we're trying to do. So we're not trying to drive down costs, we're trying to optimize cost, we're trying to reduce variation, and we're trying to improve safety of medications, the most common intervention that we'll do in the NHS every year. That's me done. Thank you.
Thank you, Mark. As a hard-bitten old fogey, I must admit, that sounds fantastic. Anyway, anybody want to pose a question, make a comment about that?
Nice easy one, Tim.
Hi, Mark. You seem to keep repeating according to the data in the medical record. Whereas in fact, I think most people know in the room that a GP medical record is probably the richest that there is. So was there any particular reason why you kept repeating that phrase?
Because we can only work on what's in the patient record. As you say, globally, we probably have the richest data set in the world in primary care. So we have the ability to actually do something quite different and lead the world in these types of solutions in primary care. So I'm just trying to make it clear that all we can work on is what's held. If there is a different view or data isn't input into that system, then obviously you'll get a spurious result. It's been a long day. So straightforward.
Yes, I mean it's, what you've said is brilliant, and I suppose in one sense it doesn't lend questions. You think, well, I either do this or not, I suppose. But it's, right, where we go?
I would like to ask you, good self, is there any implications for overruling the NICE guidelines if you have put a watertight system which challenges the GP and on his prescribing, and then he finds that he likes perhaps to overrule this. If the patient, unfortunately, or anything develops complication, would this make the GP liable?
The GP is always liable. The GP is always responsible for the care they're providing. We're just offering advice. And from a NICE perspective, NICE is very much siloed. So it doesn't really take account of polypharmacy and comorbidities very well at the moment. NICE are changing. We try to counter that by understanding drug-drug interactions and polypharmacy, because that's our core business. So what we'll present is what's safe, and what we'll present is what's nationally agreed best practice. If a GP wants to decline to accept that, and absolutely they can, they know more about the patient than we do, they can decline to accept it. We will audit that and report that back. So we'll capture when people are when a rule is triggered. We'll capture whether that rule is accepted or ignored, and we may ask the healthcare profession to explain why they've ignored that rule, depending on whether the CCG actually wants to report on medicines usage in that way.
Any professional has the right to ignore advice, but in the, not just litigation, but just in simple accountability, you've got to have a damn good reason for it, that's all. But you, as a clinician, you've got the right to treat the patient in front of you.
So everybody else can hear. I'll be able to hear you. But.
Sorry, Dan DeRose, I'm GP and Chair in Wolverhampton CCG. I was just asking a couple of things. On a similar vein, if you get a recommendation from a specialist to use a drug outside of the licence or doubling a dose, etc., or using beta blockers in heart failure for people who've got asthma, does this system will trigger? This system will be triggered, won't it?
We can code a local-based rule. So if you have agreed at a local level that that's how you want to treat a patient, and they want to double dosage because they understand that there's a therapeutic output they're trying to deliver, then we can code that. But we won't. We're not taking responsibility for that. NICE aren't taking responsibility for that. And as David said, ultimately the healthcare professional at the point always takes responsibility for it anyway.
And can I ask us a slightly different question? We use script switch in Wolverhampton,
yep.
And that always sort of gives you the most cost-effective medication. We're talking about patient concordance, and you get some old people coming in with 3-4 different boxes of the same drug, yep. And they're totally confused. And that does not go well for sort of concordance. No. Is there no way that we could use a sort of a branded generic that we could use locally? Would that be a possibility to avoid confusion?
Absolutely. So we can code local rules, and we can switch off rules within the system if you don't want to use those rules. So you have the capability at a local level to define what rules you want to implement. We're saying here's a starter set of 700. If you have local rules to support local requirements, then we can include those within the system.
Right, thank you.
Thank you. Time for one more. Going on. Well, thank you, Mark. I think that's fantastic. So I think you deserve it.